So let's check off some of the challenges that I think I heard going forward. We've got the lack of screening. It's an asymptomatic disease. People aren't coming in. We've got providers who may or may not really be on the ball in terms of treating globally as opposed to in a particular slot. Where does the specialty pharmacy come in with all of this?
That's an interesting component because with cardiovascular disease, historically, that's not been a specialty population. The patients aren't in specialty pharmacies unless they have comorbid specialty conditions. And those prescribers, you know, likely the surgeons that put in the stent, the cardiologist who's working with the patient, and the general practitioners, they're not familiar with specialty. So it can be quite a challenge. Many times, the specialty pharmacy isn't dealing with the statin therapy. The first time we will see some of these patients is with the newer medication requests for the PCSK9s.
And that's getting back to what we talked about earlier. I think that's where we need to focus is on better coordinated care management, better medication therapy management, and then closing the loop between all of the different stakeholders that are involved in a patient's care. But even then, we're going to have issues. We need to address cultural barriers, cost, demographics. There's all kinds of things that factor into patients. So it's really, it's moving from population, and this is going to be the challenge for a payer. It's moving from population-based to patient-based. Mm-hmm. So what we do, a lot of what we do is population-based, but there has to be, with a disease state like this, with all of the different comorbidities and moving parts, there really has to be more of an individualized approach.
Okay, so now we come down to something we're hearing more and more about in the literature, which is this heterozygous familial hypercholesterolemia, and if you could say that 3 times fast, you did my job. But is it underrecognized, first of all, and how common is it in the United States? Who wants to just launch into this?
I'm certain that it's underrecognized. I mean, we know that at least 1 million people have familial hypercholesterolemia or atherosclerotic disease. Say that 3 times fast. And that is probably a very low estimate. So it goes back to, are we screening people appropriately and those sorts of things.
But it's a big problem, right?
Yeah, it's a big problem. I mean, the data will say between 1 and about every 300 to 500 patients actually have the disease, and it's a big problem too because you really require greater than 50% reduction in their LDL to make a clinical impact, which is a difficult thing with the current medications we have, available to treat. And I think the other issue, you mentioned it being under-recognized, I think it is. I mean, in our practice, the application of the Dutch lipid classification is not commonly done in private practice.
What does that mean?
Well, that's just a scoring system to determine whether a patient actually has familial hyperlipidemia or not. And, when we see a patient, if that LDL is greater than 190, if they have tendon xanthomas, if they have family history of early onset coronary artery disease or personal onset, then that patient's likely got. And then you can do some DNA testing as well to prove, but I think it's just under-recognized. We often will see a patient in a primary care practice and they may have a high LDL and we don't really apply the classification to them and we just treat them.
Well, I want to get to that.
But we're going to treat them anyway.
You're going to treat them anyway, right?
Right.
But what I'm hearing from you, if I'm hearing it right, is that these are people who are going to be particularly resistant to treatment. They've got a big genetic driver.
Right.
And they're not going to respond as nicely to statin therapy as somebody else might.
That's correct, because you want to get that greater than 50% reduction in the LDL, and it's just difficult to do with statin alone.
Do you need to do genetic testing? I mean, you implied, by the way, something that would shock my teachers, that you actually looked at patients. That you look at the xanthomas, you talk to patients, you get a family history. All that is going to make the diagnosis. You shouldn't need a genetic test, should you?
That's correct. That's correct. I don't think so.
Are payers going to require genetic testing?
It depends on the payer. And how,
they are requiring genetic testing.
And really where the risk is, if you have self-funded, if you're fully funded, there's all kinds of factors that go into that. So it's across the board. I can say we're not. We're requiring physician attestation. So that's some payers, but I think it's a minority of payers will ask.
I was going to just go over this.
They might ask for chart notes or something.
If somebody sends you a request for whatever, based on a presumed diagnosis of familial hypercholesterolemia, and they say, I have established a family history, I have got xanthomas on exam, I have got this cholesterol level, are there payers who are going to say, not enough, doc, go do the DNA test? And how much does that cost, by the way?
And is the payer going to pay
well,
for
you
that?
can look at the reports of, with the PCSK9s, about 80% of the initial requests for therapy were denied. And it's for some of those same reasons. It's because in clinical practice, we don't have these types of tests, you know, diagnostic tests and genetic tests that are being done outside of the lipid levels. So when a payer has a criteria where we're requiring all of this documentation, there's just, the documentation is not there to support.
Well-
So initial 80% denial, and then on redirect for an appeal, you know, less than 60% ultimately get approved.